The main idea is that, the immune checkpoint inhibitors, for those that are not that familiar with it, are basically monoclonal antibodies that allow the immune system basically to attack the tumor itself, right? So it blocks the checkpoints that the tumor cell is able to leverage in order to keep the T cells quiet. And by unlocking them with these antibodies, then they're able to go against the tumor. But it has the possibility of breaking in self-tolerance, so leading to more autoimmune or immune-mediated toxicities or immune-related adverse events, or irAEs, as they're called in the field. And this is obviously concerning when we're having an immune activating drug in someone that has an underlying autoimmune disease, and specifically a neurologic one like multiple sclerosis, which is the most common one affecting the central nervous system, and many people are familiar with. So that was the big question, is that now that as patients with MS have better treatments and they're aging, living their lives, and with age comes a higher incidence of cancer. So it's important to make sure we have treatment options for that population as well. And they were largely excluded from the initial trials for ICIs. We really don't have large data sets or prospective studies really looking at this to give high quality data. And to do so, we asked this question, retrospectively, looking at our patients for whom this has already happened, what were their neurologic outcomes? So that was the initial motivation for the study. To do this, we actually leveraged the Medical Partnership for MS Plus, an organization that has over 1,000 neurologists across the country interested in MS and associated disorders. So when we have these kind of subset populations where it's like patients with MS that then get cancer that also get a checkpoint inhibitor, it becomes tricky to have a large amount of patients in just your own site, as one location. So through this organization, and we were able to really bring many sites across the country together. So we had 6, including, Mass General Brigham, which is my home institution, and Stanford, NYU, Stony Brook, University of Colorado, Rutgers coming up. And we basically pulled together resources, queried our electronic medical records for patients with MS that were pre-existing MS that then get this treatment. We pulled these patients, and then we ended up with a total of 65, for which we collected data on their MS history, their cancer history, their treatments, and how it went, essentially. And the basic characteristics of our data that I'd like to highlight are that they are older. The patients had a median age of 66. So, and as expected for patients that are older and they're 60 with MS, they had less active disease, right? So they were not really having flares. They're quite far out from the last flare. Their disability burden was pretty low. And only about a third of them were on active disease modifying treatments, and that too not on really high efficacy ones, like some things you may have heard of, like natalizumab or ocrelizumab. They were not so much on that, but more the older injectables. So this was the population that we had, and we looked at, how the checkpoint inhibitors they got, what they got, and how they ended up faring. And the basic outcome we were looking at is the rate of MS disease activity, whether it's just lesions on the MRI scan on serial follow-ups, or if it's a full clinical flare, they're having symptoms, MRI lesions, and whatnot. So really reassuringly for us, at least in this population of older patients with not as active MS, only 2 out of 65 patients experienced any activity whatsoever. One was just asymptomatic MRI lesions and totally fine. The other was a worsening of gait with lesions that then got better with steroids, and that was not their main, overall big complication that happened over the course of their cancer and their treatment. So this is really reassuring. Apart from these two, we also asked, are there other, there are neurologic immune toxicities or irAEs that can happen, and do we observe, a higher rate than expected or from the general population? And we did not. 3 other patients had neurologic side effects, but this was not at a rate that was out of proportion to what's been reported in the general population. So this is also an interesting and important question: is that our patients with MS, nervous system autoimmune disease, at higher risk for nervous system complications from the checkpoint inhibitor treatment? And at least in this population, it did not seem to be the case. Yeah, so that's the overall outcome of our study, which is great. And I think highlights, a need in the field. A lot of patients and providers, oncologists, neurologists were a bit hesitant to start these medications, but in a certain, we're hoping to provide that at least in a certain context that this is safe or could be safe and should be considered even early on if it is something that would help their cancer. The feedback was really great, really heartening to see and to hear. I think really highlighting that how much a question this had been on providers' minds, right? And I think neurologists get asked a lot, and these questions been working with our oncology colleagues, and we've identified in the study as well, and in my presentation, that we do need to do a bit more work now as well. These are older patients, which yes, older patients are more likely to get cancer and need treatment. But there certainly is a rise in the rates of cancer, unfortunately, in younger adults, under the age of 50. So we really don't have as much data for that population. So we cannot generalize fully to that area, right? These are patients that tend to have more relapses or closer to the last relapse that are higher efficacy disease-modifying treatments or DMTs, and that itself, may interact, or if you discontinue, is that going to cause a rebound relapse? It gets a bit tricky. But I think those are some immediate next steps, is trying to gather more data on younger patients that with MS that then develop cancer needing checkpoint inhibitors. And the other is, I think this highlights that a major gap in the field was that there have been studies in the past looking at more systemic autoimmune disease, so things like rheumatoid arthritis or polymyalgia rheumatica, inflammatory bowel disease, so not the neurologic, but kind of elsewhere in the body. And they had varying rates of relapses of their respective disease, in these studies. But MS was really either like a small amount or non-existent in these systematic reviews. And prior small studies have also suggested that the rate is pretty low, especially in older patients. But this highlights, I think, that kind of every autoimmune disorder is a bit different and has a different predisposition for how it reacts in terms of having flares or other immune side effects with this checkpoint inhibitor. So they should all be kind of studied in their own right and also be included in future larger studies. And in that vein, we are interested in looking at patients with, the MS plus or the cousins of MS, the neuromyelitis optica and MOGAD, like those other demyelinating disorders. What are their outcomes like? Because the pathophysiology is different, right? And we can't fully generalize to that population either. So these are some avenues that, we've been hearing exciting feedback about, and we were also planning on pursuing.